Yes, I'm Phil Gooden. I'm Service Manager of the IAPT services provided by Lancashire Care, known as Minds Matter.
And I'm Sarah Swindley. I'm Chief Executive of Lancashire Women's Centres, who are an IAPT provider, amongst other things. But I'm also on secondment to the Pennine CCGs to lead the implementation of the early adopter, early implementer pilot. So, yeah, it's not actually a Lancashire Care project. It's a collaborative project, which we'll talk about a bit more.
Yeah, so I mean, I suppose it's fitting, two things to say as an introduction in relation to what Claire just said. I suppose this is perhaps not innovation that's just grown in a pocket. There's kind of a national push behind IAPT for long-term conditions. But relating to some of this morning's topics about kind of third sector NHS providers, hopefully what we'll have here, if we just go to the first slide, is a good example of third sector and NHS kind of working together and hopefully delivering a service to people of Lancashire, of East Lancashire and Blackburn as one, so that it'll feel like they won't know whether it's third sector, whether it's NHS. And I suppose as well, I don't know whether it's unusual or not, but the third sector, you're actually kind of leading this, where perhaps in other cases it might have been the other way around. So, I mean, as it says there on the slide, the kind of the vision of what we're going for, and it relates to the 5-year forward view implementation document, where it talks about that extra 40% kind of prevalence target, which is sort of designed to target people with comorbid long-term physical health conditions. I know, Rachel, will sort of take some of your points, and it'd be good to have a conversation actually about some of those. But the aim really is to, through an integrated model of care, and what I mean by that is a model that delivers both physical and mental health, in some cases delivers it at the same time to people with those needs. Very early stages, and we're going to talk about kind of some of the planning and where we're up to in relation to that. I suppose money is something worth mentioning as well, because in terms of there is a little bit of money coming in, but non-recurrently, and the future sort of model in terms of funding is it's about reducing pressure on other areas of the health service, particularly acute admissions, length of stay, delayed discharges, those kinds of things that are widely reported as being very, very costly. And as we say there, it's almost, although the direction of travel is for people with comorbid physical and mental health difficulties, it's very much sort of carte blanche as to how we address that, and hopefully we can be as creative and as effective in doing that. So I don't know if you want to say, Sarah, about...
Yeah, I mean, just to give a bit of the context to this, really, this did come about from an opportunity that the CCGs kind of brought to us, saying, can you write a bid for this money to be an early implementer site? And I guess for some of you in the room, we are an early implementer, which implies that there will be future implementers as well. So hopefully some of the learning and the teething problems we might be having locally will be something that can be scaled up across the system as we go forward. So this is the national team's kind of framework for delivery, really. Just to give an overview of where we're up to. Lots of it's not very exciting, but just to highlight the procurement of work packages, which sounds quite dull, but it does actually mean there are some tender opportunities at the moment, particularly around delivering some top-up training around long-term conditions to the IAPT workforce, but then also about conducting a piece of research and evaluation of this piece of work. And some of us were at the national meeting yesterday about this, and it would be great to see researchers from the Northwest being able to lead this. So if you need details about where that bid opportunity is, I can make sure Claire's got access to that. So we've got quite a lot of support from the national team, and they're doing all sorts of bits and pieces that's effectively delivered through a Yammer network as well. I don't know if those of you who are on Yammer, it's a really useful tool to collaborate and be able to kind of share data, share documents and just ask lots of questions. So you don't have to be part of the early implementers network to be able to access that Yammer thing. You've just got to send an email and you get added into it. So lots of useful stuff on there about disorder-specific measures, all kinds of information that's going to be used in this as it starts to develop, because it is a big package of work that's going to be quite quite challenging to deliver, really. So that's where we're up to, really. We're very much in the mobilisation stage at the moment, and then the piece of work goes on for kind of 2.5 years from the beginning. But yes, as Phil says, the opportunity will be to be able to evidence that we've created cashable savings in the system by preventing attendance at A&E and GP's appointments, that kind of thing, which, given the context of the system under extreme pressure at the moment, will be a huge challenge, I think, for us. But saying that, we've got opportunities to upskill and develop and increase the workforce across the partnership. So, do you want to talk about that, Phil? Some of the stuff we've done today?
Yeah, well, in terms of, perhaps if you talk about the governance, and I'll go into the recruitment, because the plan is for existing qualified members of staff to deliver the long-term conditions work, but there's backfill money for trainees into teams. So with the 6 CBT trainees and 10 PWP trainees, the CBT interviews are actually happening today. Do you want to speak about the finance?
Yeah, and maybe a little bit about the governance, because just thinking about partnership working and integration more broadly, really, and transformation, because you start to integrate something, the project that's about integrating mental health and physical health, but actually what it becomes is about integrating something much wider than that. So we're integrating 2 different IAPT providers working, one in the NHS, one in the third sector, so there's a whole workforce and values and all sorts of stuff that we're integrating there. There's also very practical stuff around data sharing, information governance, flowing data, integrating data systems as well to collect that kind of stuff, and then integrating this long-term condition service into a wider system that's also got other bits of long-term condition services happening. So I think it's a piece of string, a piece of wool you start to pull the end of, and all sorts of other stuff starts to be unpicked as well. Lots of restructures locally around neighbourhood teams, bits of work happening in isolation as well. So lots of governance about how can we make sure this project has the most impact by making sure we've got permissions to share patients' data around that kind of system. So yeah, we've split some of the provider responsibilities, and yeah, it was quite telling, Claire, that you kind of introduced this as Lancashire Care project, because it's absolutely not. It is driven by the CCGs, and Phil and I have a really good close working relationship, and we're basically just IAPT leaders trying to make a project work on scarce resources for the best of the needs of the community. So that NHS, non-NHS stuff doesn't really massively come into play for a lot of the work that we do together. We've got a long history of working collaboratively with the Trust. But basically, it looks like Lancashire Women's Centres, we will be concentrating more on the PWP cohort and probably more on the primary care cohort, whilst the Trust will be concentrating a bit more on the high-intensity cohort and the more acute settings. Although we will change that if it starts to emerge that that's not the best way to work the workforce, because we've got the flexibility to be able to do that. We've got the national team coming to visit us in the new year as well, but hopefully by which time we'll actually have some live examples for them to be able to show them. And I think one of the things we've both found in our services, we kind of knew but hadn't really dug into the data, was the large amounts of people sat in IAPT services currently who have got a long-term condition. So Lancashire Women's Centres, 44% of our caseload has more than one or more long-term condition, which I was surprised was extremely high. So we're really interested to see what actually offering the top-up training for the IAPT clinicians will do to those individuals in service currently. We'll upskilling those practitioners to be able to work in a more long-term condition focused way with those individuals, actually produce the benefits without having to shift very much around the system. So there's lots of things we can play about with that. So yeah, and we've got a steering group in place with terms of reference, because I think that's going to be really key. We've got to co-design this in a very meaningful way. We've also got another small third sector organisation involved who are going to do community engagement and in-reach, particularly working with BME communities, which is a big need in our local area, to look at what does this mean for patients and different experiences locally.
Yeah, absolutely. I guess just to add to that, in terms of kind of the STP, the sustainability and transformation plans, this brings together sort of third sector, us as an IAPT provider, but also on the physical health side, because it's across Blackburn and East Lancs, there's different providers of physical health services. So as we sort of get moving, there's going to be, kind of 5, 6, maybe more different providers all hopefully working together as one team. So this kind of little flow chart here is the kind of the project overview. Now, as Sarah said, sort of the PWP side is kind of sitting with the Women's Centre and the CBT with Lancashire Care. Initially, we looked at kind of splitting that, but actually, just in terms of delivery, it made more sense and was far simpler to deliver it in that way. And in terms of how it will be delivered, we've got kind of 2 provisional GP sites identified there in East Lancs. We'll hopefully get a Blackburn one identified soon as well. The acute setting, I imagine, is going to come a little bit later once we get going and working kind of within GP practices. I guess as a sort of a side note, about 4 or 5 years ago, as a clinician, I worked on a long-term conditions pilot, and one of the real challenges around that was getting people with appropriate kind of mental health difficulties from local services. When I was going around trying to explain what would be kind of an IAPT appropriate presentation, what I kind of often had referred to me were people with kind of the more complex needs who in many cases had to sort of refer on for care coordination. So there's going to be some challenges in those GP sites, educating the practice staff and ensuring we get people who can benefit in appropriate ways for the interventions that we're going to offer, which is going to be crucial as we then progress in terms of what's measured and we're able to demonstrate what we're delivering and the impact that it's having. Thank you.
So yeah, just we're in mobilisation period, which hopefully won't rumble on too long. But that's there've been some sort of delays with sorting out the funding and making it all add up as well initially. So that's taken a period of time. So it won't actually look that different on the ground until next financial year. We will see 350 new patients across services this year, but then it scales up significantly, moving us towards the 25% prevalence by 2021. This is a key part of the transformation funding that allows us to do that. So Claire's got signs holding us, and we've run out of time, but I'm sure Phil and I'd be happy to take any questions or get in touch with us about how this might work.
So, yeah, give me 15 seconds. So the strengths, we talked about the partnership, the working relationships. One of the reasons an early implementation site was because of data and doing fairly strongly already. The challenges are going to be kind of in delivering this, ensuring that the core day-to-day IAPT services performance isn't impacted. That's a real risk in terms of moving qualified staff out and bringing in trainees. And the other part is actually being able to sort of demonstrate and show the impact and the savings through the data.